Hi, I'm recording this video from the annual Congress of the European Society of Cataract and Refractive Surgeons in Copenhagen in Denmark. Over the years, I've been referred a lot of patients with hypotony, either from trauma, glaucoma surgery, VR surgery, and even chronic uveitis. However, recently I've seen an increasing number of cases associated with secondary sutured intraocular lenses or yamane-style haptic-fixated intraocular lenses. The case I'm going to present is one that was a particular diagnostic and therapeutic challenge, and I hope you find this interesting. Hi, I'd like to share another interesting case of hypotony. This patient developed severe hypotony after an opacified intraocular lens was replaced with a yamane-fixated style intraocular lens in the right eye. 5 months after surgery, UBM clearly shows a ciliary body tear close to the haptic, though there is no cleft in the angle. External exploration is required to visualize the extent and location of the tear and its relationship to the IOL haptic, which is essential for accurate closure. The IOL haptic, but not the tear, is seen with the amid gonioprism. Endoscopy would be required to see the tear. The conjunctiva is opened in the area of the tear as indicated by the UBM. The area around the haptic is dissected carefully. The haptic is only covered by conjunctiva, and this is an exposure risk. From the UBM, the scleral course of the haptic is unlikely to be involved in the ciliary body tear. Nevertheless, the surgeon must be prepared to open the sclera around the haptic if required. A double scleral flap will be fashioned so that the sutures can be buried. I mark roughly 4 mm from the limbus for the posterior margin of the outer flap, and then create a partial thickness scleral flap. The flap should be longer than the anticipated length of the tear to ensure all of the tear will be visualized and repaired. I have avoided the scleral exit site of the IOL haptic as the UBM suggests that the tear does not encompass this area. The inner flap is then outlined around 1 mm inside the outer flap, gently grooving the sclera with repetitive shallow cuts. Eventually, the groove reaches the full scleral thickness so that the suprachoroidal space is entered, as evidenced by the release of suprachoroidal fluid seen here. The remainder of the flap is opened fully with the blade reversed, cutting upwards, in order to avoid traumatizing choroid or ciliary body. A thick cohesive viscoelastic such as Helon GV is generally more useful than an AC maintainer in this situation. AC maintainers either create a fountain from the tear itself, obscuring the view, or cause uncontrollable choroidal bulging. Viscoelastic creates a more stable environment in which to close a cleft, or, in this case, a ciliary body tear. The full extent of the tear is now visible under the flap. Having confirmed that all of the tear can be visualized, it can then be closed. This is achieved by suturing ciliary body band back to sclera. This is neither as difficult nor as dangerous as it sounds, and is performed by passing the needle through the inner flap and gently engaging ciliary body band circumferentially. In this case, I've not engaged ciliary body band sufficiently with the initial bite, so I will take another, before passing the needle back out through the inner flap so that the knot will be located between inner and outer flaps. I will usually put 3 throws on the suture but not lock it down until I've inserted all the required ciliary body sutures. As this is not a long tear, few sutures will be required. The tear appears to be closed adequately, but it is important to check for other neighbouring tears. There is a suspicious area on the other side of the central adhesion. This area is worth the suture as well. Unlike the previous sutures, I'm taking a circumferential bite of ciliary body, which is a better, more controlled method. At this point, all of the ciliary body sutures can be locked down. As this is a relatively small tear, I'm fairly confident that it has been closed adequately. It is important to close the inner flap robustly to prevent dehiscence if there is a postoperative IOP spike. Here I'm using 9/0 nylon. 10/0 is insufficient to prevent wound dehiscence if a very high post-op IOP spike occurs. I have buried this suture under the inner flap. This is not essential as the outer flap will cover the sutures anyway. It is important to close the inner flap tightly to maximize postoperative wound integrity. This is achieved using many closely spaced sutures. The viscoelastic is then removed. The outer flap and conjunctiva are then glued back in place using fibrin tissue glue. I also place 1 or 2 sutures in the conjunctiva if required. This is the appearance 3 weeks after surgery. The pressure remained low for the first 13 days, but then spiked to over 40 millimeters of mercury. But this was rapidly controlled with medication. And this is the appearance 3 weeks after surgery and 8 days after the pressure spike. There's a clear difference on UBM between the pre- and post-operative appearances. Thank you very much for watching. I hope you find these tips useful in your practice. So this case was particularly unusual in that there was no visible cleft in the anterior chamber, no visible cause for the hypotony. I was surprised that the ciliary body tear was so easily visualized with UBM, but this proved to be of great diagnostic value. Unfortunately, I was then able to fix the tear and restore the intraocular pressure and improve the patient's vision. So there's been a happy outcome. However, I have seen an increasing number of cases associated with this type of lens fixation in the last few years. So it is perhaps a less recognized complication that we should be aware of. And we should also be aware that it can be fixed. Thank you very much for watching, and I hope you found it useful.